So you'll remember Jennifer Bailey. Neely made it up here last time. Master's levels nurse from Hopkins, Senior Director of Quality and Transformation, and also at the Armstrong Institute. So welcome to Charlottesville.
Thank you. Okay. Can everyone hear me? Oh, it's very bright up here. So thank you for having me. Okay, I got this on now. Okay. So I'm going to talk a little bit about course intro Johns Hopkins, and then some analytic drivers that we see within our realm of quality. I do manage our quality department at Johns Hopkins. We have a process for getting data in and getting data out and using it. So I'm just going to share that framework a little bit briefly. I know that we're a little bit late on time. And then show 3 specific case examples of how we have used data to actually improve with emergency room rates, readmissions, and some quality improvement efforts. So I know that you are familiar with Johns Hopkins as an organization. Hopkins is comprised of a health system as well as a school of medicine, Johns Hopkins University and Johns Hopkins Health System. We have a virtual board that sits in the middle. It's Johns Hopkins Medicine Board that has representatives both from our health system and from the university on the board. All of our hospitals sit into our health system. We also have a large physician group within our health system of about 400 employed physicians. And then in the middle, on the bottom there, we have several joint ventures between both the university and the health system, and those include a pretty large health plan that has Medicaid population, Medicare Advantage, a military group, and an employee health, as well as a home care group and a very large now international group. Within Maryland, our clinical integrated network has 5 hospitals local to Maryland. We have another hospital down in Florida, Tampa, Florida now. You know, it's a pretty typical clinical integrated network. We have health centers that have ASCs and multi-specialty, larger health centers. And then we have smaller primary care practices, sort of this hub and spoke model that sit around our network. We do have a lot of patients seen both in and out of network, especially those in our health plan. We've heard this talked about today. This is my visual of creating value out of data. You know, that paradigm of data, information, knowledge, and wisdom. So I'll talk a little bit about how we specifically are doing so. So I know that you all are familiar with drivers of EMRs. I think, you know, EMRs to me are the key, were the key to getting data into systems. There's been a number of drivers to get us there, but the question is, how are we really now using that information at the bedside? We're starting to see data sets emerge, you know, broader than just EMRs and registries. There's a lot of HIE, Health Information Exchange data in Maryland. I'm going to talk a little bit about our HIE, which is absolutely fabulous and robust, and it's being used in really, really interesting ways to improve our health. You know, beyond that, there's other data sets that we're trying to figure out how to migrate, and we shouldn't forget about. So lots of things going on with pharmacy data. SureScripts surely has the market on that, but trying to integrate that data in better ways, things like patient data, so patient-reported outcomes, whatnot. I kind of consider these to be the 3 key components as we move forward within managing the health of our populations. Interoperability, we've heard, you know, CMS talk a ton about. So that's pretty, you know, well documented. But then really using that to do predictive modeling, as we just heard a lot about. And analytics, I think analytics are a key driver. And by that, I really mean business intelligence tools, both at the reporting level, but also at the point of care and with our frontline physicians. I use this framework often to talk about processes. So we have people, process, and technology. I'll show you that framework in the context of our sort of journey to how we get good information in to be able to use it effectively. So for me, it starts with the team. You got to get data in, and you can't have physicians being the only people doing that. So we have a lot of processes to get good data into the system with, you know, office staff, nurses, physicians, et cetera. So using the whole team to get data into the system, because the more data in, the more we can do those analytics and risk prediction. Carefully orchestrating the workflows, so we know that without a good workflow, you can't, again, get the right information in the right place. So just carefully orchestrating these workflows is something that has been very helpful. We have Epic. I believe you guys are an Epic client. The University of Virginia is Epic. We have Epic. We use a lot of clinical decision support. We have a really great best practice advisory committee with lively physicians that debate the use of these and implement them in a very thoughtful process. So we have a lot of best practice advisories and clinical decision support that are getting really complex and fun now, and help drive change into the system. Again, I've talked about interoperability. So one of the things that we do as a best practice is have a very, very specific data specification process. So, at this point in the journey, we have a lot of good data in, but getting it out, especially out of Epic, for those of you who aren't familiar, is very challenging. We have a data steward there's people on our quality team who know these CMS data specifications inside and out. They work with the frontline clinicians and staff to understand the workflows, because again, keep remembering that you have to find where the data sits into the system. We have these standard definition processes that we use, very structured templates, and we want to make sure that we can repeatedly get the same data out of the system. So using this process has been very key and helpful. We have created a lot of custom reports out of Epic using this process, and I think others have had some struggles in that regard. And then once we get the data out, we have this triple check process in terms of QAing the data. We have our programmer, our analysts, and then of course our frontline users. We have physicians that QA all of the data, go through it line by line to see where we are missing things. I call it the squeaky wheel. We have these certain physicians who always say, my data's wrong, it's not right. And we said, okay, then you come help us make it right. Come part of the process. And they've been great, and they've been our biggest advocates now. And most of the time, all I have to say is, Doctor has reviewed the data, and then everybody knows it's accurate and right. So I mentioned clinical analytics. We have a lot of different types of analytics that we share with our frontline physicians and staff, and I'm going to go through those in more detail during some case studies. But we have a dashboard, a pretty typical provider dashboard that's multidimensional quality measures, workflow, operations, RVUs, et cetera. We do different types of analysis. So this one on the bottom happens to be around overall provider rating and communication scores, emphasizing to physicians how important it is that they communicate effectively to improve patient experience. They seem to resonate with that. So registries are becoming increasingly important. I actually chair our data trust, which is our governance body around data. And in the last 4 months alone, we have had 4 requests to send data to external registries. And Hopkins has a lot of different subspecialties that we participate in, so there's lots of different specialty society registries that are emerging now. And so registries are important for benchmarking. And then we also within Hopkins have created a lot of internal registries within Epic. We have found them to be a very useful way of getting data out of the system quickly and repeatedly. We've used the Epic standard ones. We've also created our own custom ones. So we have a certain high-risk population for a grant that we created a custom registry, so we can use that to do reporting over and over. So I do love registries, and they are here to stay, apparently. Within Hopkins, we have a predictive modeling system called the ACG system, the All Clinical Group System. It was developed by our School of Public Health, and we use it to predict the risk of patients in their health. Specifically, we're looking at a prediction of patients that will be rehospitalized. It gives them a probability score. And it determines, really looking at cost of care and determining how likely are they to be readmitted or admitted in the future, and we're considering those patients to be high risk. And then we have a series of interventions that we do for those high-risk patients. And the beauty of the ACG system, it's actually a standalone software system that's sold all around the world and used with different EMRs, is that it can use different data sources to calculate this algorithm. So it could use claims data, could use EMR-only data, or a combination of both. We're doing a feasibility study right now of testing it with just EMR problem list data, which is turning out to have a high correlation to our standard ACG outputs that we get through claims data. So the ACG system is one tool that we are using to use predictive modeling. We actually feed that back into our Epic system. At the bottom, you see a little flag, it's in the banner. It says the patient's at high risk for hospitalization. And then we use that so that schedulers, for example, try to get patients in right away. But we have, like I said, a series of interventions that we use to get that information back to clinicians. So it's not just, using all that data to get a predictive score is one thing, but how do you feed it back to the front line and really get people to use it practically is sort of really the ultimate next step. And then also I mentioned in Maryland, we have a very, very robust health information exchange. And our HIE is now, we have been working really closely with them to produce some analytics at the state level. So this is an example where we're feeding them ADT and emergency room messages all over the state. All of our hospitals are feeding them that data, and then they're aggregating it to create some population analytics. So this is Baltimore, a blown up map of Baltimore, and you can see there's very specific areas within Baltimore regionally where we have patients who are using the emergency room excessively. So now we've looked at, within those geographies, where are we missing urgent care access, where are we missing primary care access, how can we help fill those holes? So this is where you really start to use data and information to help manage your population more effectively. So this, again, just to sort of recap our journey that we just went on, we got data into the system, we developed analytics, predictive modeling, and used it for population analysis. So I'm going to show you again, or talk about now, 3 very specific examples where we've seen some really good outcomes in using this process. The first one is around improving emergency room rates. As you just saw from that last map, we have a pretty high incidence of emergency room use in our area. Despite the fact that we have a lot of urgent care and a lot of other primary care, we are well above benchmark than we want to be. So we developed an intervention. As I mentioned, CRISP, which is our Maryland State HIE, all hospitals sent emergency room events to them. So we took those events back out of the system and we aggregated them into a database and started doing a lot of different analysis around those events. And I'll show you some of those in a minute. We also simultaneously created a clinical community of users multi-stakeholders, who wanted to help use that data and information to develop interventions. So these are clinicians, emergency room doctors, primary care, urgent care, nurses at the bedside, if you will. This clinical community framework is something that we use often within Hopkins. We feel it's a good way to foster peer learning and really stimulate a set of interventions and performance improvement plans. So I mentioned we have this aggregate analysis now of all of these emergency room visits. And we've looked at it, we've sliced the dice and data a different way. So one of the things we looked at was, are these, what percentage of these are going to Hopkins hospitals? What's our sweet spot? Where can we really intervene here to say, okay, we have both primary care Hopkins patients going to Johns Hopkins hospitals, what percentage is it that we can really help and fix these high utilizers? So we, again, this is just an analysis, but you can see they go all over the state, that's for sure. Again, we looked at these zip codes. This is another blown up version of that map where we're really trying to see, we've narrowed things down into one very specific zip code. This is sort of similar to the hotspotter intervention that was done within New Jersey, where we're looking at where we're having really high pockets of patients using emergency room use, And then we've really broken them apart even within that zip code, how to help those patients. We have community health workers and neighborhood navigators working in that area to help that population. We've done analysis around time of day. So we looked at certain practices to see when patients were going to the emergency room during office hours and non-office hours, and those where we were having large gaps of patients seeking emergency room care off hours. We expanded their office hours. You can maybe familiar with some of these sites. So we have sites in Hagerstown and Frederick and North Bethesda, so not too far from here, where we're realizing that we need to expand office hours to meet their needs. So this is a really practical way of using the data to look at operationalizing how we are making performance improvement plans. And this all came from our HIE data, every single bit of this analysis. As I mentioned, we have a group of, we're talking about high utilizers. So these are patients who have 3 or more emergency room visits compared to total number of visits, where we're looking at where we're having large pockets of high utilizers versus those that are just seeking care one time. So just, again, different types of analysis. And then, as I mentioned, we got a whole bunch of people together. We had so much data that we wanted people to brainstorm together. We use a technique called design thinking, where we get people together, brainstorm, use a lot of sticky notes to develop concepts and prototype solutions. And then we use a quality improvement technique called a fishbone diagram to help inventory and categorize those ideas. This is the next level of taking this was from all those ideas, and we put them onto an impact grid where we talked about which interventions were going to yield a high impact and had a high probability of succeeding versus those with a low impact and low probability. And the ones next to our green little smiley, those interventions are the ones that we've started already implementing through our clinical community. So this has resulted in a decrease in emergency room rates. This is our Medicare ACO. Over the course of the past year, we have seen a decline in emergency room rates, straight emergency room rates, as well as the emergency room rates that have led to hospitalizations. So next I'm going to talk about our readmission reduction work that we've done. And again, using our HIE, we have set up a process to notify all of our practices when patients are in the hospital. So CRISP, again, our statewide HIE, gets ADT events from every single hospital in Maryland. And then they, in turn, take those ADT events and they send them out to the primary care physicians. The primary care physicians say, we actually send them a panel of patients every single month, and we say, we want to know about this group of 300,000 patients. And then we get those notifications automatically, real time, once the patients hit the emergency room or the hospital. So this happens to be a discharge hospital notification process. It comes directly into our Epic system, into our outside messages folder. From there, we have a pool or a team of people that monitor those messages, and we've created a smart form within Epic, and we create a transitional care assessment, and we contact the patient and document that and try to bring them in within 7 days. We, of course, monitor that with data. Now that all that information is in Epic, we've created custom reports that look at the discharge events coming in and whether or not a phone note has occurred and whether or not a follow-up appointment has occurred. As many of you are probably familiar that you can bill transitional care management when those events have happened, and then we do these sort of dashboards and monitor sites to see how they are performing with those rates. We felt like whenever sites were doing transitional care management right after discharge that we saw an improve or a decrease in readmission rates. We take that down to the practice level as well. So this is a lean framework called an A3. An A3 is a paper size. For those of you who aren't familiar with it, it's in 8 by 11. You're supposed to always keep it on one piece of paper, but essentially it's a quality improvement plan. It looks at defining the problem, analyzing it, measuring it, most importantly, I guess, for this group, and then improving, which are your true action items. So we bring those analytics down at the site level and help them understand how they are specifically doing with those measures. We do this at every single one of our sites, and everybody is working on something different depending on things that they need to improve on. This is also another tool that we got from CRISP. This is a Tableau tool that looks at readmission rates by service. We've looked at it from different payers. We're looking at our entire populations and finding out where it is that we're needing to intervene on. I don't know if you can tell by this specific view, but we sort of identified GI as a problem area, and then we can really work with those different specialties. So we're doing a lot of cool different analytics and looking at different angles of the problem. So again, here's how we're doing as a result. We have seen that patients seen within 7 days tend to have a lower readmission rate than patients not seen within 7 days. We've been validating that data with our internal payer now for several years when we implemented this process. We've also seen in our Medicare ACO, our readmission rates have gone down. And our commercial payer, CareFirst, which is our Blue Cross local payer, we've seen a decline in readmission rates with them as well. So we're seeing this across the board in our varying populations, a decline in readmission rates. And just to share, Maryland, in general, had a higher readmission rate than average. So going down is a very good positive thing, but hopefully getting us closer to the norm of the national average. The last thing I'm going to talk about is more traditional quality measures. So this is our ACO. We have about 35,000 patients in our Medicare ACO. We're in an MSSP Track 1 ACO, started in 2014 and are due to renew this year. We started out a little slow. We took a while to try to get dashboards, internal monitoring dashboards to see how sites were performing. We work with outside practices who don't have Epic, had different EMRs, and didn't have data necessarily ready to go from these EMRs. There was a lot of data for meaningful use ready to go, but the ACO measures are, of course, ever so slightly different, and they weren't didn't quite fit what we were looking for. So we actually worked with their EMR vendors to develop custom extract reports to get exactly the ACO measure specifications out to get a dashboard. So we now have a dashboard that we share on a monthly basis with all of our providers in our ACO that gives you entity, site, and provider level performance, completely transparent, even within the non-Hopkins and Hopkins physicians, where everybody sees everyone else's information. We have supplied for them run charts. Of course, this is one measure in particular, depression screening and follow-up, where we're looking at our progress over time at our varying entities. Again, we use our A3 process. This is one of our sites in Germantown. One of our initiatives was to improve our Medicare wellness visit rates. We felt that if we just get patients in the door for a wellness visit, that our physicians can address a multi-set of problems. Specifically, we really wanted to improve our depression screening and our fall risk assessments, and those are pretty easy process measures to get once patients walked into the door. But again, we're taking that same process where we're defining that problem, analyzing it, measuring it at the local level, and helping them understand where they are and where they need to improve. And I can't emphasize that enough. When we give sites these big dashboards and business intelligence tools, they don't know what to do with it. Frontline clinicians don't know what to do with that information. It's very overwhelming to them. So I have a whole team of people that work and distill it down and give them only the information that they need so that they know what they need to improve upon. I think a lot, I love data and I like to look at it, big data, but getting it to the frontline clinicians really needs to keep it really simple. So again, we've seen pretty great improvements in our ACO quality measures. 7 of our ACO quality measures had greater than a 3% improvement than year prior. Our fall risk in particular went up from 18 to 66%. Depression screening went up from 34 to 63%, which were our two major initiatives. And you can see, started out the lowest. They had the biggest increase, so that's good news. But this is something that we will continue to track on. It's not in here today, but looking at our 2016 performance, we continue to make even better progress. We're trending higher than where we were at the same time last year in every single measure, so that's great. So again, just to summarize, we use a very specific process, get good data into the system, understand how it's in so you can get good data out of the system, and then get it to your frontline clinicians in an effective way. And we've seen some very good results around improving some of our quality metrics. Thank you.